Good morning, everyone. Today I am going to discuss about anti-manic drugs and anti-anxiety drugs. First, I am going to talk about anti-manic drugs, drugs for mania. Okay, the main treatment used here is lithium. Okay, lithium is a small monovalent cation. Okay, it's a cation. It does not produce any acute effect, but on prolonged use, it can act as a mood stabilizer. Okay, that's what you have to remember. So it is a small monovalent cation that does not produce any acute effect. It is not used for acute effect, but on prolonged use of lithium, it can act as mood stabilizer. And in normal person it has no psychotropic effect in normal persons. And how it acts, I will show you the picture of the diagram. And it acts by inhibiting the hydrolysis of inositol 1 phosphate. Okay, which is required for this enzyme, which is required for the regeneration of IP3 and DAG. So inositol monophosphate and diacylglycerol. This is the picture. So this is the GQ protein. Okay, GQ protein. There is a phospholipase C which is present in your phospholipids. Okay, the phospholipase C will hydrolyze your PIP2. PIP2, phosphoinositol diphosphate 2. It will hydrolyze the PIP2, IP3 and DAG. Okay, so the DAG will activate your protein kinase C and do the action, and IP3 it will go into the cell and stimulates the calcium release. So it does the function. So this is the function of normal function of physiology is IP3 DAG. Okay, so phospholipase C present in your phospholipids, they hydrolyzes the PIP2 to IP3 and DAG. DAG will go into the cell and activate the protein kinase, and IP3 will activate the calcium. Okay, so what lithium is doing here? Let's see this diagram. So this is phospholipase C. PIP2 is converted by phospholipase C to IP3 and DAG. So the DAG will cause increased protein kinase and IP3 will cause increased calcium, that are leading to effects. So after the effects, what will happen? IP3 will be hydrolyzed to IP2, then IP2 will be hydrolyzed to IP1. Okay, this is taken by the enzyme called inosine monophosphatase, IMPase. Okay, inosine monophosphatase. Lithium is inhibiting this enzyme. Okay, inosine monophosphate. So the recycling of the enzyme is inhibited. So there are two areas the lithium is inhibiting, that is from conversion of IPT to IP1 and IP1 to inositol. In these two steps, the lithium is inhibiting the pathway for the regeneration of the PIP2. Okay, after its effects, it should be recycled back to BIP2. Okay, and this process is inhibited by your lithium by inhibiting the enzyme inosine monophosphatase. So hydrolysis of inosine monophosphate is inhibited by your lithium at IPT to IP1 and IP1 to inositol. Normally, the inositol is converted into PI, then PIP, then PIP2, and finally it will act by phospholipase to again IP3 and DAG. So this is the cycle. So the regeneration of the IP3 and DAG is inhibited by your lithium at two steps: IP2 to IP1 and IP1 to inositol. So this is the main mechanism of lithium. So coming to the lithium, it has narrow margin of safety due to low therapeutic index, and TDM is very essential. That is therapeutic drug monitoring. The serum concentration monitoring is very essential for the lithium because of it has low safety and narrow margin of the safety, and due to low therapeutic index, it is not safe drug. And for the action to happen, it takes around 1 to 2 weeks for the action to happen. Okay, so it is not used for acute condition. It's just used for only for the prophylaxis. Now, long-term administration, it acts as mood stabilizer. So it is a drug of choice for the prophylaxis of your bipolar disorder. So lithium T-half is around 24 hours, 1 day. Okay, T-half of lithium is 1 day. And acute mania, you cannot use lithium. So if you want to use lithium, it can be used with your benzodiazepines like compound, which has immediate effect. Okay, benzodiazepine will do the immediate effect like lorazepam, that must be added due to your slow action of the enzyme. You can start even in the acute mania, but it should combine with benzodiazepines to calm the patient. And in patients who are not controlled by benzodiazepines, you should give atypical antipsychotics like olanzapine. Okay, what is most commonly used drug is olanzapine. Atypical antipsychotic may be added. So coming to your plasma concentration of your lithium, for the maintenance therapy, it should be around 0.5 to 0.8 milliequivalents per liter. But for your acute mania treatment, it should be around 0.8 to 1.2 milliequivalents per liter. And the toxic symptoms are manifested if your plasma concentration exceeds more than 1.5 milliequivalents per liter. So for your acute mania, it should be 0.8 to 1.2. For maintenance therapy, it's 0.5 to 0.8 milliequivalents per liter. And the toxic symptoms occur if it exceeds more than 1.5 milliequivalents per liter. And particularly, it has more interactions with diuretics. The thiazides will inhibit the or decrease the renal excretion of the lithium. It will may result in your toxicity of the lithium. So thiazides decrease your renal excretion of the lithium. And why it's so? Because we know the thiazides will excrete the sodium and water. Okay, so excess sodium loss. So they want to compensate. They want to compensate the sodium loss. What should do? What they will do? They will reabsorb the sodium. So lithium is also a cation like the sodium, so it will also get absorbed in your proximal converter tubule. So that's why it causes toxicity. So I will tell again. Thiazides normally causes water loss and sodium loss. Okay, because of the sodium loss, there should be compensatory response to save your sodium. It should be it happens in the reabsorption of the sodium in the proximal converter tubule. So since the lithium is also a cation like sodium ions, it will also get absorbed to the proximal converter tubule, and it causes lithium reabsorption and cause toxicity, excessive toxicity of the lithium. Okay, this is the mechanism for interactions of diuretics like thiazides with lithium. So what are the side effects it can cause? The side effects, we have mnemonics as lithium. Okay, LITHIUM. L for leukocytosis. So since it causes leukocytosis, it is used in the treatment of cancer therapy, cancer-induced leukemia, chemotherapy-induced leukopenia. Since it causes leukocytosis, it increases the white blood cell count. Okay, and I for increased, both the I these cause increased. Okay, causes increased. T for tremors. Tremors is the most common side effect of your lithium. And H for hypothyroidism. Okay, it can cause hypothyroidism. And increased urine. It can increased urine means diabetes insipidus, nephrogenic diabetes insipidus. So it causes diabetes insipidus. So it can be used for the treatment of SIADH, syndrome of inappropriate ADH secretion, where there will be more water reabsorption. Water will not be excreted. Since your lithium is precipitating your diabetes insipidus, it can be used for the treatment of SIADH, where the water will be absorbed and not excreted. And in mothers, it can cause Epstein's anomaly. If you given in pregnancy, the baby will have Epstein's anomaly. Teratogenic complication is Epstein's anomaly. So lithium, we have the side effect lithium. L for leukocytosis, so it is used in the cancer-induced leukopenia. I for increased tremors. Tremors is the most common side effect. H for hypothyroidism. I for increased urine. It can precipitate nephrogenic diabetes insipidus. So it can be used in syndrome of inappropriate antidiuretic hormone (SAADH). In mothers, it should not be given in case of pregnancy because it can cause Epstein's anomaly in babies. And since uh, it can cause water and retention also. Sodium and water retention or the other adverse effects with the lithium can cause, because of the sodium and water retention, it can cause acne and weight gain because of sodium and water retention. In ECG, it can cause your benign and reversible elevation of T waves in ECG. So what are the alternatives we have to lithium? We have carbamazepine and valproate. They are anti-epileptics. So they are useful in manic and depressive psychosis, bipolar disorder. So carbamazepine and valproate can also be used in manic depressive psychosis. They can also be used for your acute mania in place of lithium. You can replace lithium with carbamazepine or valproate. And valproate, if you talk about only the valproate, it is a drug of choice for the treatment of rapid cyclists. For example, if the bipolar disorder person have rapid cycles, for example manic phase and depressive phase, both of them together for more than 4 cycles per year, then we can give valproic acid. Valproic acid is more effective for your rapid cyclers more than 4 cycles per year. And benzodiazepines like your lorazepam, I told you, it is drug of choice for the acute mania when combined with the lithium. And olanzapine and other atypical antipsychotics, they show efficacy in bipolar disorder as well as the acute mania. They are used when they are not sensitive to benzodiazepines. So if you talk about your lamotrigine, it is specifically useful for your depressive phase, not in the manic phase. In the depressive phase, the lamotrigine is useful. And coming to the lithium toxicity, there is no specific antidote for your lithium. And the only way of removing the lithium from your body from the poisoning is dialysis. You should do the dialysis. So dialysis indicated when the serum lithium level is more than 4 milliequivalents per liter in acute overdose, if it is more than 1.5 milliequivalent per liter in chronic overdose. Okay, so dialysis is the only effective therapy for removing the lithium from the body, because there is no specific antidote for your lithium. And dialysis is indicated when your serum lithium is more than 4 milliequivalents per liter in case of acute overdose, and in case of if it is more than 1.5 milliequivalents per liter in chronic overdose. Now I'm going to talk about your anti-anxiety drugs. So what is responsible for your anxiety? Reduction in your GABA activity or increasing the serotonergic activity may result in activity. We know that benzodiazepines are GABA analogs, so they will increase the GABA, so they will cause anti-anxiety effects. But if the GABA is decreased, then it will precipitate the anxiety. So it is very explainable. And serotonin is also a mood stabilizer. If there is increase in serotonin in your body, it can also result in anxiety. We know that the side effect of SSRI is anxiety. Most common side effect after nausea is anxiety, because it causes more serotonin in the synapse. So increased synapse will cause anxiety. So it is also explainable. And anxiety is due to mild CNS stimulation. Okay, because of the mild CNS stimulation, you will get anxiety. And drugs commonly used for your anxiety or CNS depressant drugs like benzodiazepines, or those we can decrease the serotonin levels like buspirone. So increased serotonin will cause anxiety, so you should decrease the serotonin levels. Drugs like buspirone. So for chronic anxiety, we are giving chlordiazepoxide because it is longer acting, and for it is specifically used for chronic anxiety. So chlordiazepoxide is useful for chronic anxiety. And for short lasting acute anxiety, we are having oxazepam, lorazepam, alprazolam, and diazepam. We can give oxazepam, lorazepam, alprazolam, and diazepam for short acting anxiety states because they are short acting. And particularly with liver disease, we should give these short acting drugs, because the short acting drugs will not go into the liver, they will get directly conjugated in the kidney. So for such drugs like oxazepam and lorazepam, they are the short acting drugs. They are safe in the elderly patients. And the diazepam is not safe because it is metabolized in the liver to form oxazepam, so it is not safe in your liver disease. So the drugs which are act directly conjugated to the kidney are safest, which are having the shortest acting are the safest. We have oxazepam and lorazepam. So the benzodiazepines are most commonly used anxiolytic drugs. Coming to buspirone, azapirones, buspirone, gepirone, and ipsapirone, they act as partial agonist at presynaptic 5-HT1A receptor, and they thought to decrease the release of the serotonin. Since the increase in the serotonin will cause anxiety, because they have partial agonistic action, they can decrease the release of the serotonin. So they have the effect in anxiety. They can treat your anxiety. So, but the therapeutic effect of these drugs take up to around 2 weeks. Okay, that's why they are ineffective in your acute anxiety states like panic attacks. They are not useful. So they are only useful for your chronic anxiety and mild to moderate generalized anti-anxiety states. Buspirone, gepirone, isopirone. So they act by partial agonist at presynaptic 5-HT1A receptor. They decrease the release of the serotonin. Because of decreasing the serotonin, they are treating the anxiety. But the therapeutic effect will take up to 2 weeks for the action, and therefore they are ineffective in your acute anxiety states. They are equally useful for your chronic anxiety. They are indicated for your mild to moderate generalized anti-anxiety states. Other drugs having the anti-anxiety activity are propranolol. For stage fears like performance anxiety, there will be increased sympathetic activity in such cases. So for decreasing the sympathetic activity, you should give the propranolol, beta blocker. And hydroxyzine is an antihistamine activity, antihistamine drug having the anti-anxiety activity. So they can also cause profound sedation. Okay, but we cannot use for anti-anxiety because they can cause profound sedation. They can limit its usefulness because of profound sedation. Hydroxyzine is an antihistamine drug having anti-anxiety activity. And this all for your anti-anxiety class. And thank you for your kind attention.